The first priority in the care of a patient with hypoxemic respiratory failure is to maintain adequate tissue oxygenation to prevent permanent tissue damage, such as hypoxic encephalopathy or myocardial infarction. And so if a patient's oxygenation changes, you need to immediately investigate and improve it with supplemental oxygen. And then you need to monitor closely to make sure that the therapy remains adequate, which we often define as keeping the PaO2 over 60 millimeters of mercury and the SaO2 over 88%. And you have a lot of options for delivering supplemental oxygen. You have non-invasive things like a nasal cannula or mask, or something more invasive, you can deliver oxygen through an endotracheal tube to assure a higher concentration of inspired oxygen. Now, although it's undeniably important and possibly life-saving, oxygen therapy does have potential toxicities, and it's important to titrate the oxygen to the minimum level needed to maintain adequate oxygenation. Because we've seen that high levels of supplemental oxygen can cause oxygen toxicity in experimental animal studies. Although we don't have definitive data for humans, it seems like pulmonary damage can occur after 16 to 24 hours of exposure to inspired oxygen concentrations of greater than 55%. Now, not all patients are going to get oxygen toxicity, but we don't have any way to reliably predict which ones will. So this is kind of a threshold where we think damage might begin, but of course some patients are just going to require toxic concentrations of oxygen in order to keep them alive and avoid tissue injury from hypoxia. And so when you're facing a situation when a patient needs potentially toxic levels of oxygen, the best approach is just to continually reassess for the ability to safely decrease the oxygen concentration while maintaining adequate oxygenation. In general, the need to maintain adequate tissue oxygenation should outweigh the theoretical concern of harm from prolonged exposure to high oxygen concentrations. Another concern with oxygen therapy is that rarely, in patients with chronic obstructive lung disease, oxygen therapy can cause worsened hypercapnia. Again, maintaining adequate oxygenation takes precedence here, but it's something to be aware of. And the mechanism of the increase in the PaCO2 in this setting is not well understood, but it's probably due to worsening of VQ mismatch.